Okay, good afternoon or morning, depending on your time zone. And welcome to today's webinar entitled Chargemaster Basics. We appreciate you taking time out of your busy schedule to join us for this 60-minute web session. Before we start, let's cover a few housekeeping items. All attendees have been placed on mute in order to eliminate background noise. We encourage you to interact with our speaker throughout the presentation by typing your questions and comments into the Q&A panel. Your questions will be answered following the presentation as time permits. We may not get to all of your questions live, but we will be providing you with an FAQ document with all the questions and answers received throughout today's session, as well as the PowerPoint presented and a link to the live recording within 5 business days. I'm going to reiterate that we will be providing you with an FAQ document with the questions and answers received throughout today's session, as well as the PowerPoint presented, a link to the live recording within 5 business days. You will receive that via email. Today's presenter is Wendy Kennedy, Director of Revenue Integrity Services here at Vitalware. Wendy, the show is yours. You now have the floor.
All right, thanks, Julie. Hope everyone can hear me okay. Today we're going to talk about Chargemaster Basics. This is something we were asked to do for some folks that maybe don't have as much experience working with the Chargemaster, just to get a better understanding of, exactly what the Chargemaster is and how it works and what it's for and why it's important. And I know back when I first got into healthcare and started out in coding, the Chargemaster was kind of this, magical unicorn file somewhere that did things that I didn't have to do as a coder. And early in my career, I really was not sure actually what the Chargemaster was. We're going to talk about that today. This is our disclaimer statement. Basically, this webinar presentation is current at the time it's published, designed to provide accurate and authoritative information in regard to the subject matter covered. The information provided is only intended to be a general overview, with the understanding that neither the presenter or the event sponsor is engaged in rendering specific coding advice. So we won't really get into any real coding advice, but this is a disclaimer that we use for all of our webinars. So again, the learning objectives of today's presentation is we're going to answer the following questions. What is the Chargemaster? Why is the Chargemaster important? And how does the Chargemaster work? So we're going to start out with what is the Chargemaster? A Chargemaster, which is also called a charge description master, probably most often called a CDM, is an electronic comprehensive listing of items billable to a hospital patient or patient's health insurance provider. This data file includes items such as procedures and services, supplies, devices and products, and also drugs. A CDM is used for multiple purposes. I've listed some of those here to facilitate billing, to capture and categorize revenue, to assess and manage resource utilization, to facilitate the Medicare cost report, to support the budgeting process, and in some cases for inventory control. So we'll dig a little bit deeper into some of these later in the presentation. So what else do we know about the Chargemaster? CDM touches every hospital revenue producing department, meaning that any clinical department that provides a service or a product to a patient has a department CDM that is used to charge for those services or items. A CDM also describes the nature of the services or items provided through descriptions, HCPCS codes if required, units of service, and then associated monetary charges. A CDM is also a dynamic document or a snapshot in time. And this basically just means that if we export a hospital Chargemaster today, this is going to provide us with a snapshot of the services, supplies, devices, and drugs that are available to be charged today. These items often are changing. New drugs come out, drugs get discontinued, new supplies are invented, and sometimes discontinued. And then also, oftentimes new technology brings new services, or things could change based on the AMA pushing out CPT code changes. So as those descriptions change, as new codes come on board, there are adjustments made within the Chargemaster file. So the most basic data elements in a Chargemaster include the department number, charge code, charge description, revenue code, CPT or HCPCS code, modifier, and the price. So first I want to talk about department number. So within a Chargemaster file, each department is designated via a department number. So that is a unique identifier that identifies that particular department. So the department number for radiology will be different than the department number for the emergency department or speech therapy and so on. These are specific to each hospital, so this isn't something that is standardized across the country. Each hospital comes up with these hospital department numbers themselves and designate those to each department throughout the Chargemaster file. These are typically straight numeric, and most hospitals that I've worked with is a 4-digit number. So you'll see here 7230 or 7240. We'll talk about these a little bit later in more detail. The next basic element is the charge code. So this is going to be that unique identifier that identifies a specific charge, meaning a specific service that is offered, such as a chest x-ray, or a particular drug such as Zofran, or even perhaps a device, like a pacemaker. These are unique, so there are no two that are the same in the Chargemaster file. So each charge has its own unique charge code number. These are specific, again, to each hospital. So the hospitals develop these themselves inside their patient accounting system. I've often seen the charge code be called other names such as procedure ID or charge ID, or procedure code. So this may be named something different depending on which hospital system you're currently on. These are also typically numeric. Each different system has a different character length. And then these also may reflect the department. So as you can see here on this little snapshot at the bottom of the slide here, the first 4 digits of the charge code are the same as the first 4 digits of the department number. So that's something that many of the hospital systems generate. So they build the charge code specific to the department number, but in other systems, this might not be the case. So perhaps with like Epic, where you build the charge one time and it may be used by 7 departments. Each of those departments uses that same charge code. And then you're able on the back end to see who generated the charge. So it may not necessarily be specific to a particular department number. The next element is the charge description. This is a text description that identifies the item or the service. Again, these are also hospital specific, so each hospital comes up with their own verbiage for each charge description. Each hospital's patient accounting system also has its own set of character limitations. So I would say the average of what we see is somewhere between 26 and 36 characters, meaning that you can only build a description that holds 26 to 36 characters, including spaces. So if you've ever looked at detailed charges and noticed that some of the words look strange or are cut off, that's because whoever built those charges has tried to take a long CPT description that could be a paragraph and squeeze that into 36 characters. So often items are abbreviated. When you really run out of space, the first thing most folks do is start deleting vowels, since our eyes can still figure out what words are without the vowels in the middle of those consonants. So there are some examples here at the bottom. So like IM injection. IM is a standard abbreviation that represents intramuscular. So that charge is for an intramuscular injection. And then the last charge there, X-ray of tibia and fibula, 2 views on the right. So you can see how often you have to get creative to be able to squeeze things into these small spaces. The next data element is the revenue code. This is the first data element that actually is universal. So the revenue codes are published by the National Uniform Billing Committee. And so all hospitals across the country use the same revenue codes. These are directly linked to the cost, meaning if you look below and you see that that first charge there represents an emergency room charge. Revenue code 450 represents emergency room. So you can see that the cost of providing an emergency room visit is assigned to revenue code 450 because the cost and the revenue code are both associated with emergency room. There are also specific associated billing requirements for many of these revenue codes. Oftentimes, as you see down there with the vaccine administration example, that revenue code is 771. That revenue code only means vaccination administration. So as you can see, the ER charges above that all can be used with revenue code 450. The vaccination administration revenue code is only 771, and that's the only procedure that can be used with that revenue code. There are also billing requirements by payer. So there may be some payers that want you to assign a specific revenue code and CPT combination that other payers may not prefer. We often hear our clients say, you know, we don't know how to build these charges. We've tried to use the revenue code for treatment room, but Cigna or Aetna or Blue Cross doesn't like that revenue code and they reject those claims, or they don't pay us for those items. So those are all things that hospitals need to learn and work together between the Chargemaster people, the managed care people, and also the billers to make sure that those revenue codes are set up appropriate for the payers. And then there are general revenue codes as well as revenue codes that are more detailed. A good example of that would be revenue code 300, which represents laboratory general. So that's just any basic laboratory test. There's also a revenue code that gets more specific, that is 301. And 301 would be assigned to any charge that represents a particular chemistry type lab test. And then also another example, 306 would represent pathology. So some of them are very generalized, others are very detailed. Best practice when assigning revenue codes is to assign the revenue code that is at the highest level of specificity. But in most cases, using the general revenue code is not considered non-compliant. Next, we have the CPT and HCPCS code. So these would be the CPT or HCPCS code that is published that represents the particular service or item that you are charging for. These also may have specific payer requirements where maybe the managed care payers are looking for a particular CPT code, but Medicare prefers a HCPCS code be billed on Medicare claims. And so with those differences in billing requirements, most charge masters will have a default CPT HCPCS column and perhaps multiple alternate columns. So the default column is typically set to Medicare. I've seen hospitals use other payers as their default if that is their largest payer mix and their Medicare payer mix is very low. So they would set a default and then they would set alternate. There could be alternate 1, alternate 2 CPT codes. And so those would be changed based on whichever payer is set up to identify that alternate. So if Blue Cross wants a particular CPT code for those ER visits, you would set up a special column in your Chargemaster for Blue Cross and assign the code accordingly. Obviously, we want to make sure that our description and our CPT code are the same. So if we build a charge for an ER visit level 5, it is imperative that that CPT code represents the same thing. That's where you get into, obviously, compliance risk if those two don't match and you're thinking you're billing for one thing and send a CPT code out on the claim that represents something else. Same thing with revenue code. Some payers may pay based on the revenue code, so it's also super important that the correct revenue code is assigned and that it is able to be used in combination with the particular CPT code. The last thing here to talk about with the codes is that you may hear this often in your jobs of hard coding and soft coding. So basically, hard coding is when the CPT code is assigned in the Chargemaster file, and every time that particular service, drug, or supply is charged, that CPT code is what goes on the claim. When something is soft coded, it is coded by the coder. So it might not necessarily be the same each time because it's done on each account at the time of coding. Oftentimes we will see in the OR, The OR services will be charged by time, so that the amount of time the patient actually spent inside the operating room. And so those procedures can vary, and those will be coded by the coder. The next thing we have here is modifier. Modifiers obviously are specific to particular codes. Not all modifiers can appropriately be applied to all CPT codes. And I would say the most prevalent modifiers are those of laterality. So your RTs for right, LT for left, and 50 for bilateral. There are also other ones that describe digits and the providers, such as your GPs for your physical therapists, your GNs for your speech therapists. So it could also actually identify the provider. There are also modifiers on the professional side for things like co-surgeon or assistant surgeon that would be applied to CPT codes in those scenarios. They're 2 digits, and each CPT code can have multiple modifiers. So this is another data element where you might have built in your Chargemaster a modifier 1, modifier 2, modifier 3. I believe you can use 4 modifiers per code on a claim, which doesn't happen very often. It's very rare that you would see that. And then another thing I wanted to point out here is there are modifiers, that will bypass CCI edits and get payment for 2 services done on the same day. Those are the old 59 modifiers. A lot of the payers are still using those. Medicare switched over to the XS, the XU. And so those basically mean that these 2 services typically shouldn't be billed together, but in this particular circumstance, this is a special circumstance. It's a different body part or a different side or something separate and distinct. And so at VitalWare, when we do our CDM reviews, we discourage our clients from adding those modifiers into the Chargemaster and prefer that it's a more conservative and compliant approach to attach those modifiers to the CPT codes at the time of coding, or perhaps if your hospital has failed claims specialists, to apply them then, so that we can ensure that the documentation supports the use of those modifiers, since they will result in additional reimbursement. The next element that we have here is price. And so I think I hear often people get confused with price and cost. So this is not the cost to the hospital, but this is the price that the hospital is charging the patient. But when prices are set, they are very much directly related to the cost of providing the service. So oftentimes, hospitals will determine what their cost is and then take their cost times 3, and that may be what they use as their price. There are all different kinds of pricing strategies and charging strategies that exist out there. There are strategic pricing initiatives that occur in hospitals where it may be recommended to increase prices in one area and lower prices in another area based on either the amount of patients that come through those areas or perhaps particular contracts that you may have with managed care payers. And then also there are reimbursement considerations when you're setting prices. So one of the biggest pitfalls I think that hospitals get into is coming up with a pricing strategy and rolling that out. So they're very consistent in the way they price their services and their devices and their drugs, but then they're not necessarily coinciding with the way managed care contracting has negotiated their reimbursement. And so they oftentimes get caught up in that lesser of charge language, where basically the contract says, let's use this ER visit level 5 as an example. Perhaps the managed care contract with Cigna says that if you bill me a 99285 CPT code, I'm going to pay you $2,000. And so in the contract, it says we will pay you the contracted rate or lesser of charges. And in this instance, since the charge is less than $2,000, Cigna is not going to pay the full rate of $2,000. They're going to pay less than that because you're charging them less than $2,000. So that's a very, very important consideration when coming up with your pricing strategies and validating those with your contracts. Also, with today's transparency regulations and more to come in 2020 for those, it's extremely important that your pricing strategies make sense. We're putting our charge masters out there on the web. We're, publishing those to the public, which includes our potential customers or patients, as well as our neighbors, our competitors. And so we want to have a tight strategy for assigning prices to our charges to make sure that we are competitive in the marketplace. And then there are some instances where the price is not populated in the actual Chargemaster file. Some systems will push the price for drugs specifically straight from the pharmacy system. And that is typically because the pricing strategies in pharmacy are typically based on what the cost of the drug is. So like the average sales price or average wholesale price, and that's marked up based from that. And as that changes, so does the price. And so pharmacy typically will manage that pricing strategy, and oftentimes the price will come from the pharmacy system. And so inside of the Chargemaster, that price column will be blank. Some other data elements that you may see in Hospital Chargemaster, and this is not all of them. Obviously, each facility is unique and houses different data inside their system. But a couple others here are the cost. So sometimes when you're dealing with supplies, the cost might be populated, or again, even in pharmacy. And fee schedules. So what are your fee schedules for each of your facilities? And then also sometimes manufacturer is one of the data elements in the Chargemaster file. So other files that exist outside of the main hospital CDM file live in ancillary systems, such as pharmacy or materials management, where the supplies are housed. And this slide is a visual representation of some of the data elements in a pharmacy file. So you can see here, there is a procedure code, a CDM description, revenue code, HCPCS code, and price, which is much like we talked about earlier. But then in this file, we can also see the cost of the drug, the NDC or National Drug Code, the form of the drug, such as a solution, or this could be a tablet. You can also see the strength of the drug, how many of these are in the purchased pack. So there are lots of other data elements in the pharmacy system, and way too many to be able to show on one slide where you could actually read it. The pharmacy system, especially in Epic and Willow, houses tons and tons of data. So going back to what I mentioned earlier about the CDM being a dynamic file, these CDM files are often changing, like I mentioned, based on perhaps new technology, CPT code changes. With pharmacy, the biggest one is the acquired price. So what did we acquire those drugs at? What was our cost? And keeping those markups standardized. And then also, again, as these CPT codes become obsolete, as new drugs come out and kind of old drugs get retired, or a drug is found to no longer be safe and taken off the market. These files are always changing. So lots and lots of movement within these Chargemaster files. One thing that is extremely important to note too is that if you ever hear people say, don't ever say delete when you're talking about Chargemaster, historical charges inside of a Chargemaster file are never ever deleted. They are made inactive. And so there's a big difference. Once a charge is inactive, it's no longer able to be charged on a patient account. So there typically is some type of an error message if somebody tries to hand key a particular charge code that is no longer active, and it won't allow that charge to be entered. So as they become obsolete, either, like I said, based on discontinuation of a supply or device or a recall or something, they are turned off in the Chargemaster, or made inactive. And you know, I think the easiest way to describe that, because we do have clients that have never turned anything off, and then they've got hundreds of thousands of charges that they're trying to manage when most of them aren't even being used. But it's like a light switch. You can turn it off, make it inactive, and if you decide, oh, I didn't mean to do that, I did that in error, I really do need a propofol charge, you can literally turn that light switch right back on, make that charge active again and usable to anyone who needs to charge for that. So don't be afraid to inactivate charges that you're not using. Typically a great time frame to look at is look at 12 months, and then some people feel more comfortable looking at a 24-month period. So if a particular charge isn't used in 24 months, then maybe you don't really need that. All right, so we've talked about basically what the Chargemaster is and what kind of data elements are in the Chargemaster. So let's now answer the question, why is the Chargemaster important? Obviously, we know here at VitaWare why it's important. We've made a business out of building a tool that supports maintaining the Chargemaster file and all of its complexities. And I think as technology continues to advance, we continue to be on our toes to keep up with that and to continue to help clients better analyze their data and interface this information with other systems throughout the hospital. The biggest reason that the Chargemaster is so important is because all patient revenue is generated from the Chargemaster. So any patient revenue comes from the Chargemaster file. So if you're doing a service that's not in your Chargemaster, you will not generate any revenue for that. And so with no revenue, obviously you have no reimbursement. So this is just a snippet of an itemized bill that I wanted to show as an example. This is a part of a page of multiple pages of charges for an outpatient account. And as you can see, there are some codes here that have CPT codes in that second column, and then there are some charges that are blank. And basically all that means is, you know, there's not a CPT or a HCPCS code for every single service, every single drug, or every single supply. So it is appropriate to charge for something even if there's not a code for it in most instances. But just be aware that you're not always going to find a code for, oftentimes many of the self-administered drugs don't have codes. Even the ones that do don't get, a lot of them don't get reimbursed. But one thing to note there, that there isn't always a particular CPT code to assign to things. And then you can see here just some examples of what these charges look like. So you can see there's a venipuncture, chest x-ray, various lab charges, and then there are some drugs, some observation hours, and then also down there towards the bottom there is some nuclear medicine testing. And so every single one of these charges came from the Chargemaster, perhaps through various type of charging mechanisms. So since all these charges that come from the Chargemaster really is the driver of the billing process. Once all of the charges for a particular patient are entered, these charges pass through the patient accounting system and onto the patient claim or UB04 form. And I've shaded the middle section there on the UB as a slight pink shading on that form that you can see. And that's the area where all of the charges from the CDM populate. There's sections lower on the UB towards the bottom where the diagnosis codes, ICD-10 diagnosis codes and ICD-10 procedure codes populate. But that middle section there is where the Chargemaster driven things appear. In addition to that, anything that is charged, like the example I gave before with the OR being charged by time, so that charge will come across, the coders will code that surgical CPT code, and it will all marry up nicely on the bill here. So you'll see the charge and the CPT code both married on the claim. So in this section, you'll find the revenue codes, the descriptions of the particular service, CPT codes, the data of service for each line, as well as the units of service provided. So if someone had 2 chest x-rays on the same day, you'll see a unit of 2. If they received 4 milligrams of Zofran, J2405 will show on the UB with a unit of 4 next to it. And then also of note, you will see all charges here on this claim form, including those that are covered and those that are not. So there is a section on here for non-covered charges. In addition to driving the billing process, the Chargemaster is important for other reasons like cost reporting. Most Medicare certified providers are required to submit an annual cost report to CMS. And this report contains provider information such as facility characteristics, utilization data, cost and charges by cost center. In other words, by department, which is why that information is so important to be able to track using your charge data. And this is tracked both in total and for the Medicare population that your hospital serves. Also, the CDM can be used for budgeting and resource utilization, as well as in some occasions tracking inventory such as supplies, if perhaps your organization does not have a separate materials management system, which is rare these days. So let's talk about how all of this actually works. Let's start with this visual here, basically representing that the CDM is in the patient financial system. That's where it's housed. And then there are interfaces linking it to perhaps materials management, the EHR, the order entry, and the clinical systems. And so let's talk about clinical system interfaces with the Chargemaster first. And using radiology department as an example, oftentimes the radiology department has its own radiology subsystem. And so an X-ray is ordered in the order entry system, and that order is sent over to radiology, and the radiology department is notified to perform a test, let's say a chest X-ray. The tech is going to acknowledge the chest X-ray order and perform the test. And then once that test is completed, the radiology tech will designate that in the radiology system. And then this designation of complete is going to trigger a charge for a chest X-ray to be added to the patient's account. So the charging mechanism here is charge on completion, since once the test is actually completed, the charge is generated. So I know that was a lot. So let's kind of walk through this a little bit more visually. So on the left, we'll start from left to right. We've got the order entry system where that chest X-ray is entered. So someone is requesting it to be performed. Radiology is going to acknowledge that. The X-ray will then be performed. It will be completed, and then a charge will be generated. Once that charge is generated, it's going to go through the patient accounting system, over to the billing system, and eventually end up on the claim. So I want to walk through another example with the lab. Excuse me. Lab is charged slightly different than radiology. And so let's use a CBC, or complete blood count, as an example here. So someone orders a CBC, they put that order into order entry. The lab tech is going to acknowledge the order, saying, hey, I've received this order. I acknowledge this order. I'm going to now go perform this lab test. And then once the results are populated in the system, the charge is going to be generated. So in this instance, this would be considered a charge on result mechanism. And again, the charge is kicked out from the patient accounting system through billing and onto the claim. Pharmacy charging is a little different yet. For some hospitals, this might be accurate. You might not be doing this particular operations at your facility. So in all of these instances, you know, the order for a particular service is linked to a charge for a particular service. In pharmacy, the drug in the pharmacy system is linked to a charge for the drug in the Chargemaster. Or even, you know, if you're an Epic client, it'll be in your pharmacy Willow file. So you'll have shell records in your Chargemaster and detailed charges in your Willow file. Basically, the order is entered, it is acknowledged. Oftentimes the nurse goes to the patient, they scan their bracelet identifying that this is the correct patient. It's going on to the correct patient account and into the correct patient EHR. The drug gets administered, and then the charge is generated. Again, could be generating the charge from Willow or from the pharmacy module at your hospital, and sending over the price, the NDC, and even the units of the drug that was provided. So another way that charges can be entered or get onto a claim is through documentation via the EHR. So not everyone may be doing this, but the systems have gotten very, very sophisticated in recent years, and hospitals now have the ability to charge via their documentation. So there is this elaborate behind the scenes build that happens where hospitals can create the linkage between the documentation and the charge. And when certain things are documented in the patient's electronic health record, it actually triggers the charge to be automatically sent through the patient financial system. I've personally seen this used most often in the emergency department, and most specifically for assigning the facility evaluation and management, or E&M level codes, where various nursing interventions are documented behind the scenes. The systems is assigning points for each of these, totaling those points and arriving at a final number, which is linked to a particular level that is then triggered to be charged through the system. So based on everything that we've reviewed today, I'm hoping that you can see how, the CDM truly is the heart of the revenue cycle. It is touched by many areas, and many areas are dependent upon it. And again, all patient revenue comes from the CDM. So it's so important for hospitals to properly maintain their charge masters. And it's vital that charges are created for all of the services, drugs, and supplies that are actually billable to ensure that proper reimbursement is attainable. So as we know, we can never be charged, or we can never be reimbursed for something we never charged for. So it's extremely important to maintain your charge master, give it the attention that it requires, that your hospital deserves from a revenue perspective. And then also to keep the revenue that you already have. So as we know, the biggest difference between soft coding and hard coding is that when we assign a CPT code to a charge in the charge master, every single time we do that charge, that CPT code goes on the claim. So if we assign the wrong CPT code in our charge master, then every single time we do that service, we're going to build the wrong CPT code. So, give your charge master some love and the attention that it needs. Keep it updated. Double check yourself. The other thing that, as you can tell, there is a lot of technology involved with charge master maintenance and charge capture. And so with all of these intricacies and all of these system interfaces, it is just extremely vital that you validate that all of these interfaces are still working. One of the things that I like to do to be able to monitor this process, and we offer this as part of our Chargemaster reviews here at VitalWare, is to look at some claims. The best way to see if all of these things are still working as designed is to look at some real life examples and see if those charges are accurate. Do your departments know how to charge? Are these orders for chest x-rays linked to the appropriate chest x-ray charge, or did someone accidentally link that to an ankle x-ray? So validating those things through charge capture audits and claims reviews, and obviously using a technology such as VitalWare's Vital CDM tool will help you maintain an accurate charge master and have obviously a very positive impact on your bottom line. So I hope this has helped you gain a better understanding of the basics of the charge master and how it works, why it's so important. And with that, I will turn it back over to Julie to see if anyone has any questions. Julie?
Yes, Wendy, that was fabulous. Thank you so much. And as Wendy just said, we'll now begin the Q&A portion of the webinar. As we're going through these questions and as time permits, please make sure you type your questions in the Q&A panel. Again, if we don't get to them live today, then we're still going to create an FAQ and send it out to everyone with all the questions and the answers to the questions received throughout today's session. So let's go ahead and hit on the first question, Wendy. Who has determined that there are only 36 characters available?
That is determined by your vendor. So if you have Meditech versus Epic versus Cerner, the character limitation for your particular system will be different. So that is set by your hospital system that you're using, your patient accounting system.
Okay, great. Next question. When applying more than one modifier, are alpha or numerical modifiers supposed to be listed in any order? Or is one preferred to be on the charge line first, alpha versus numeric?
Okay, so when there are more than one modifiers that are applicable to a particular CPT code, the guidance is to put first the one that impacts reimbursement. So if you have two separate modifiers, and I would say basically the best way to test that is the one that is going to pass ACCI edit. So let's think. Maybe an XU and an RT. So the XU would be the first listed modifier, and the RT, designating that it's on the right, would be the second modifier listed on the code on the claim.
Wow, that was awesome. Okay, next question. The patient has and I'm gonna attempt very, very hard to say this correctly, manometry with pH monitoring. The pH monitor is removed the second day. Which day does the charge go on the claim, day 1 or day 2?
That one, I'm going to have to look at that CPT code. So we'll put that in the answers when we send them out. I don't want to answer that incorrectly.
Okay. All right, sounds great. All right, next question. Should ICD-10 PCS codes also have corresponding charge codes?
I've not seen this ever done. I've heard of it. Maybe it's like a unicorn. But typically ICD-10 procedure codes are entered by the coders. And so most of them are going to be, we don't use most hospitals. It is not required, let's say it that way. It is not required to use an ICD-10 PCS code on an outpatient claim. And so those are typically used on inpatients, and the PCS codes, like I said, go down there in the bottom section of the UB. They are applied, typically they're surgical, they are applied by the coder. So they don't necessarily need to live in the Chargemaster because the charges are still going to be generated. So let's think about, if a patient has a CABG and the OR charges for that procedure are going to be entered, and then the inpatient coder is going to read that open heart surgical report and apply the appropriate ICD-10 PCS code, and the charge is going to show at the top in that pink section of the UB that we had circled, and then that PCS code is going to be at the bottom. So no, not necessarily would you ever need to do it with the PCS codes.
Okay, great. All right, so this is a two-part question, so I'm going to go with the first one first, obviously. You referenced modifier 59 as being old or obsolete. Are all payers now recognizing the X modifiers?
They are not. So Medicare prefers the new X modifiers, but there are still payers that are not recognizing them. And the best way the best way that I've ever found anybody determine who wants what is to try it. So usually the hospitals that I've worked with have tested a claim to each payer with the new modifier to see if it goes through, unless there's some kind of published information they can get from their payer as to which modifiers set that they prefer.
Okay, so here's the second part to that. You referenced XS and XU. Should other X modifiers be considered for replacement of 59 modifier?
Yes, there are. I think there's one more. I'm having a brain freeze.
You know what? And it's probably because you have so much information in your brain. Maybe this one,
I know.
maybe this one is another one that we can. Yeah, we can include this on the FAQ document to ensure we have the accurate answer.
Perfect.
Okay. All right. So this will be our final question due to time. What about inpatient bedside procedures? Should they be included in the CDM?
Inpatient bedside procedures typically are included in the CDM as long as they are not included in your room and board. So things that are separate from what you have included in your room and board could be things that you could do at the bedside. An old rule of thumb for that too is definitely you'll want to charge for those bedside procedures that are done by somebody outside of the floor. So if a nurse, if you have a patient on 3 West and a wound nurse comes up from the wound care department to do something to that patient, then absolutely, because we know that nothing's been built into the room and board for that. And I think the biggest factor is to determine what is it you're charging for in your room and board, to determine which bedside procedures can be charged separately, because obviously anything that is considered routine nursing would not be charged separately on an inpatient. Okay.
All right, and we do want to apologize for those who have submitted a question and we did not get to them live. We're sorry about that. We do want to be very considerate of everyone's time. So we're going to go ahead and end the webinar. But again, the FAQ document that you will receive via email, along with a copy of today's PowerPoint and a link to the live recording that will be sent within 5 business days, will have everyone's questions and answers included. So thank you again for joining us today, Wendy. As always, you did a fabulous job. We hope everyone found this session informative. And if you would like more information, if you like what you saw today, if you want to share this with other groups within your organization and you're a current client, VitalWare client, please feel free to reach out to your account manager directly and they can give you all this information. Or you can contact me directly at events@vitalware.com. Also, to stay up to date on future VitalWare webinars, we invite you to follow us on LinkedIn, or you can go to our website, and under the Resources tab, there is a webinar section, and you can see all of the future webinars posted, as well as view all of the past webinars. So again, thank you for joining us, and thank you, Wendy. We really appreciate your time. We hope everyone has a great rest of your afternoon.
Thanks so much.
Thanks, guys. Bye-bye.